Welcome to America's Heroes Group.
And welcome to America's Heroes Group, our roundtable this week with our partner Jesse Brown, VA Works. August is National Wellness Month. I had to change the page there. Today is Saturday, August 13, 2022. This is Sean Claiborne, the co-host. The host you just heard on the top of the hour was Cliff Kelley. Our executive producer is Glenda Smith, and our digital media producer is Ivan Ortega of Scouts Arnold Productions. And we have a great show for you today. And also, don't forget to look at us on Facebook Live or live streaming right now. And also, newly launched our YouTube channel. Go and check out us on YouTube and see our archive shows, or all our old shows are on YouTube and also on Facebook, and also our website as well. So we have our panelist with us today, Dr. Anthony Acosta. He's an attending emergency medicine physician at Jesse Brown VA, and he serves as a geriatric physician and the champion of geriatrics. He works at the emergency medicine medical student coordinator at the VA, and also is a field surgeon for the Joint Forces of Medical Detachment of the Illinois Army National Guard. How you doing today?
Good. Thanks for having me on.
It's my pleasure. So tell us what you want to talk about as far as what's going on with the Geriatric Emergency Department accreditation. What's new at Jesse Brown, from my understanding, this is something that's brand new at the Jesse Brown VA?
Yes. So a couple of years ago, the National VA Geriatric Emergency Medicine Council decided that they wanted to start to engage the local emergency departments in geriatric care. Currently, about 50% or half of our veterans are over the age of 65. And so it was important for us to provide safe patient care and good quality care to our older veterans. And so we became part of this program, and we started working on getting accredited through the American College of Emergency Physicians.
So you say about 50% of veterans are over 65 right now. So our veteran population is getting older, as is the general population in this country. What are some of the challenges that you see with caring for an older and aging generation?
So our geriatric veterans, our older veterans, sometimes their complaints are a little bit more vague. So it's harder to tease out why they're presenting. Their functional mobility is declining. There's polypharmacy. They're on a lot of medications. And so as we get older in general, and as our veterans get older, the care becomes a little bit more complex, and we want to make sure we're providing quality care to our veterans and to our older population.
Okay. And what are some of the things that you see are most common with veterans that are older?
For the chief complaints for the emergency department, that they run the gamut. I mean, it could be falls, it could be chest pain, shortness of breath. Right now, given the current state of the pandemic, COVID is a big one. But we see the very same presentations at the VA of our older population that we do in the general ERs. So chest pain, shortness of breath, the very typical bread and butter emergency medicine.
Mm-hmm. And then, so when you did your work with the Army National Guard, so you're a field surgeon for the Army National Guard, how does that transfer over to what you do at the emergency room?
Well, I think it's why I enjoy working for the VA, right? As a military physician, I enjoy taking care of my soldiers. That's part of the joy of doing the work, and being at the VA allows me to transition that to what essentially is my civilian role. And so I can take that same enjoyment of caring for my soldiers, and on the National Guard side, I can bring that to the care at the VA. And it is a enjoyable type of work for me, at least. Yes.
Let me ask you this, a personal question, if I have your permission. Have you been deployed?
So I was overseas last year. I was in Ukraine. Before all of this happened, I was a task force surgeon for the 33rd Infantry Brigade Combat Team. I was their task force surgeon. As a physician, I deployed for 3 months, and so I was out there in Lviv, Ukraine for 3 months. It's almost been, it's more than a year at this point.
Okay, is the 708th Med still part of the 33rd Brigade? Is that,
Excuse me?
The 708th Medical Battalion, is that still part of that brigade?
No, we're 708. I don't think they are. Honestly, I don't know.
That was my old unit. That's why I remember for a quick minute I thought we were attached to you guys before I got out. I got out in 2004, roughly around there. That's when I was actually let go. But 2001 actually was supposed to ETS. but that's a whole nother
Okay.
story. So when you're doing like triage and things for older veterans, what are some of the things that doctors who maybe don't have a lot of experience with the military population maybe want to consider when they're treating older veterans in their hospitals? Because a lot of veterans that are older are using civilian hospitals, but some veterans feel more comfortable going to a VA hospital.
Sure. I think one of the things that we had to do for obtaining accreditation with ASAP for our geriatric emergency medicine program was we had to create a quality care initiative. And one of the things that we found with our veterans was that sometimes they would come in for chest pain or shortness of breath, but they wouldn't tell us that they were having trouble walking or there was a functional decline and they weren't safe at home. And so as part of our program, we created our fall risk screening program. And so all of our veterans currently who come into Jesse Brown VA who are over the age of 75 get screened for a fall risk. So we ask them, do you feel unsteady when you walk? Have you fallen in the last year? And if they answer yes to one of the three questions we asked, then they screen positive for a fall risk. It lets our team know that we need to address that before they go, because sometimes my dad is Marine Corps, serving the Marine Corps. My uncle, he'd be a little stubborn, right? I'm not trying to make a blanket statement, but they're not going to tell you outright that they're having issues walking. And so they, sometimes we need to bring that out of them. And so that's how we address that as part of our program, was with the fall risk and specifically asking them, are you safe? Do you feel safe walking? And so I think that's one thing to keep in mind, taking care of our veterans, is that sometimes there's a bit of there's some pride involved in letting you know that they might need help. And so asking specific questions may lead you to better care, essentially.
And then psychologically for older veterans, because we always hear about the number 22 a day, 22 suicides a day and so on. That number goes back and forth. Some people say 20, some people say 22 or more. A lot of those people don't realize a lot of those veterans that are committing suicide are seniors. They're from the Vietnam era. They're from the Korean War era even. So when you see signs where people are coming in, and especially one thing that's always and we think about not necessarily as a stereotype, but we think about losing your faculties, your mental faculties as you get older, as an older veteran. What do you see from the front lines of treating veterans who are seniors psychologically, mentally, and how they're treating themselves in their everyday life?
Can you ask that question again?
So how are veterans caring for themselves? Are they doing a good enough job as seniors? As you're looking at the Vietnam era veterans who are maybe suffering from maybe depression, or maybe they're alone, maybe they don't have anyone to talk to. How are they handling that? When they come in to see you, are you recognizing and seeing these things? Are you seeing a trend in any kind of way of how older veterans are taking care of themselves?
So I think my views are a little skewed, right? I see the veterans who have access to our system, and so those veterans who are Vietnam era that need help, they're coming in and requesting help. And so I think there's plenty of veterans out there who don't have the resources, or who don't know that the resources are there for them if they need them. When I see a veteran that comes in who I feel or my teammates feel need psychiatric care, we have care at Jesse Brown 24/7. I can call the psychiatry team to come down and help assess. We have social work accessible. And so, I think from my perspective, I see the veterans who are coming in asking for help, but I know that there's being on the National Guard side and dealing with soldiers who don't have access to VA care yet, who don't have those resources yet. I know that there are veterans out there struggling. And so I guess that's another point to keep in mind when you're caring for older veterans, or any veteran or any currently serving member. If they come through your ER, just to keep that in mind, that there may be other issues going on that need to be addressed, and that, the VAs are out there to help. And so maybe if in your civilian practice you can't take care of them, we are here and willing to take over.
There's one thing you'd like to see as your first mission in your field. This is a new accreditation for the Jesse Brown VA. So what is your goal and your mission? Like, first off, what's your first task in trying to get this accomplished?
So the first task was to identify what we felt was something that was needed to be addressed within our ER, right? Specific to Jesse Brown. We have a lot of older veterans. We're nationally, the VA sees about 50% geriatric cases. For us, it's right around the same, 49%. And so we, as a team, identified falls as something we were concerned with, and we wanted to make sure we were making veterans safer, right? So as they come into our ER, addressing something that maybe we were missing, right? We know that veterans are coming in for falls, but we're also taking care of veterans that are coming in for other things that that may have safety issues going home. So I think the first and foremost attempt was to make safety it always is a priority, but making sure our veterans were safe when they leave us, right? So that was the main intent of the program. And then from here, this allows us to get numbers. How many of our veterans are screening positive moving forward, right? How many veterans over the age of 75 are screening positive? And are there specific things now that we can identify that we can address moving forward, right? Are we seeing veterans that need more physical therapy? And so can we collaborate with our physical therapy department to have somebody see these veterans after they leave our department? Or is it a polypharmacy issue, and do we need to bring pharmacy in? So I think this first step was a chance for us to identify something we felt we needed to identify and then build off of moving forward.
I think that's really powerful what you guys are doing. And one thing that you mentioned, a couple of things, which brings me the curious question, and the reason I'm asking you these questions, and we've had other doctors on before, is because you're the first doctor that I've ever talked to who's actually specializing with the senior community and specializing in taking care of our older veterans. So are veterans, in your mind, from what you've seen in your experience, are older veterans doing a good enough job keeping up with their medications and doing their physical therapy?
So it's a struggle, right? On any given shift, I'll see a veteran who's on 21 medications that they need to be. It's not that they're on unnecessary medications. And sometimes the veterans I'll ask them, why are you missing doses? Or they'll come in for worsening of their chronic condition, and I'll ask them, what happened? And they're like, it's too many medications. I can't keep track, right? We have programs to help some of those veterans if they qualify. Home health nurses. Our pharmacists are fantastic. Our ID pharmacists will work with them. Maybe it's putting things in packets so that they have everything, punch out packets, and they don't have to worry about what type of medications they take. And so the resources are there, but it definitely is, as our veterans get older, some of these things become much more nuanced, and they need more help. And so if the support isn't there, if the resources aren't there, hopefully that's where we can step in and provide some of that.
How about on the physical therapy side of it?
So mobility, part of the accreditation was making sure we had access to mobility aids 24/7, right? Because as veterans come in, they can come in at 2 and 3 in the morning for a fall at home, and they needed access, or they don't have a cane, or they don't have a walker. So part of the accreditation was making sure our emergency department had access to those devices 24/7 to hand out before a veteran left our ER if they were going home that day. But there are veterans who do require occupational therapy, physical therapy, and we have a very strong PM&R program at the VA. And the veterans who need access to that care, they're getting it. One of the next steps of all of this geriatric focused programming and the fall risk is how do we are we identifying more veterans that are at risk for falling that need CT that aren't getting this addressed, right? And so if we identify that as something that's going on, we're ready to make the next steps to pursue more of a relationship with the ED and physical therapy moving forward.
Now, and this is another kind of somewhat a semi-personal question, but really more about your experience. Do seniors have, from your polling, and maybe you did this not intentionally or asking people directly, of course, but do seniors tend to have a discomfort or not be happy with the word geriatric?
I haven't seen that. I don't typically refer to my veterans as geriatric, right? I know I've gone into the room and I've discussed, let's say, chest pain with the patient, and I said, hey, look, based on your age, you're at higher risk, right? You're older. And they're like, no, I'm not, I'm younger, right? They'll correct me right away. They'll tell me I'm not, I take care of veterans that are in their 80s, 90s that are still fully independent, still driving, right? And so I know they will, they'll take me to task if they don't like a word that I'm using. They're not afraid to tell me. But I definitely, when I go into a room or I'm talking to family, I don't use the word geriatric. I think that's more of a academic term. I'll tend to tell them, hey, based on your risk factors, you being a little bit older is usually how I say it. I would never say, you being geriatric, although,
Although it's out
could
there,
happen.
that term does fly around every now and again. Certain hospitals won't name any names, but sometimes in the civilian world we don't quite get see that same respect. So do you now with older people who are older, people who are senior veterans, are they doing a good enough job of taking advantage of the technology that the VA system is now trying to roll out? Because I know the VA system is trying to get more technology savvy, use more tools that can help people connect with their doctors or nurses and get care. How is the senior community grabbing this?
So I don't, being an emergency medicine doc, I'm not involved in so that would be more of the primary care side, right? And so being a emergency medicine physician, I'm not the one that's doing the telehealth visits. And although I will say that the VA was, they have been trying to get at this point, we all should be trained in using the telehealth system and having that available for our veterans. From my perspective, when I'm seeing a veteran in the ER, and I'm looking through their chart and seeing visits, I see that there's telehealth visits available. I've seen that veterans are utilizing that resource. Some of our older veterans who have a hard time coming into the VA are maybe getting their, follow-up appointment via telehealth, so they're not having to come into the VA. And so that's from my perspective, but I think that might be a better question for the primary care guys who are out there actually seeing these veterans on a day-to-day basis and engaging on the telehealth side. I will say that that there are more veterans that I feel like are using the My Health Vet, which is our online portal to access care. And so I've had, this is anecdote, I don't know numbers, but I've had some of my older veterans say, hey, when will this be available in my portal, right? So these are older veterans that typically would stereotypically be, not used to using technology, but they seem definitely engaged, and they're accessing their portal and they're finding their information, and they know that it'll be posted shortly after their ER visit. So, from my perspective, at least, it's just end of one anecdote. It seems like some of the veterans are catching on and utilizing the technology a little bit more.
So walk me through a typical night when you're at the ER. So I'm guessing you're not getting gunshot wounds. When we think of ER, we think of and especially in a city like Chicago, you're thinking about all kinds of just really crazy stuff in the middle of the night that people end up, having these bad ailments. What do you normally see in a VA situation, particularly in a market as big as ours in Chicago?
So it runs the gamut, right? If a veteran feels like he can get to me safely, he's going to drive, right? I've had veterans come in with a full-blown breathing issue like COPD, where they probably should have gone to their closest hospital, and they'll drive 45 minutes from Indiana because they prefer getting care at the VA. And so you can have pretty much anything can walk through that door, right? We have the shortness of breath, the chest pain, and sometimes Chicago Fire, they will, if you are a veteran and you identify yourself as a veteran and they feel like the transport time is safe and they feel like they are not overutilizing their resources, they can transport a veteran to the VA. So my last shift, I think I had 3 runs from the Chicago Fire Department. And the Jesse Brown VA, we're not a STEMI receiving center. We're not a stroke receiving center, right? So those are hospitals that are set up to take ambulance runs that are in the field. They're called a stroke, or in the field they're called a STEMI, but that doesn't mean that we're not prepared to take care of those things if they walk through the door, right? Mm-hmm. I've had plenty of patients that come in with chest pain that I've identified as a heart attack on their EKG, and we call our cardiology team, and they take the patient to the cath lab, and they get the same care they would get in any other hospital. Mm-hmm. The only difference between us and any other community ER is that we typically care for the adult veteran, right? That's our niche. And so any veteran who walks through that door and identifies themselves and says they want emergency care, they will be taken back to us or to our fast track area, depending on their complaint. And we are more than ready and willing to take care of them. We've had veterans who didn't realize we weren't a trauma center come in with gunshot wounds in the middle of the night, or a stab to a non-critical part of the body, thinking that we have trauma surgery on call. We have Cook County or Stroger now right down the street. So in those cases, we stabilize the veteran as best we can. And then usually we're on the phone with Stroger saying, hey, I have a veteran who has trauma. I've stabilized him. I need to send him over to you guys, and we send him.
I think that's amazing how people, like, especially, and I've seen this before. I wanted to give you guys some credit. I had a friend of mine who passed away. He was an Army veteran. He was just right after the Vietnam era. So we have to wrap up really quick. We're running out of time. But I remember we got on the phone. He was having some health issue. We got on the phone with a nurse, and she said, if you don't get him to the hospital tonight, he's not going to wake up tomorrow. And we got him in there, and they took care of him, and he had the best care I'd ever seen. So my hat's off to you guys. You guys deserve a salute. Really appreciate your time. Dr. Anthony Acosta is an emergency attending medicine physician at the Jesse Brown VA. Thank you, and thank you for your service.
Thank you for having me on. I appreciate it, and thank you for letting me talk about the geriatric program a little bit.
Anytime. This is America's Heroes Group. We'll be right back.